started? So with that, we'll call up our first speaker, who's Fadi Shamoun, who is going to talk about the PAD epidemic, medical strategies, education, and data review.
Hi, good morning. Good morning. It's a pleasure to be here. It's a beautiful venue. It's a shame to say that I've lived here 15 years, never been in this property. It's truly beautiful. Thank you for the invitation, and it's an honor to be with you this morning. So we'll start. My talk will cover the epidemiology and prevalence of vascular peripheral vascular disease, examine some of the pharmacologic interventions, some of the changes that we've seen over the past few years, in addition, associated cardiac condition. Here's an example of a patient in my clinic, 62-year-old, was quite active gentleman, the usual, probably Arizonian citizen with hypertension, hyperlipidemia, a little bit overweight, drinks every night, smoked in the past. He ran a lot of businesses up until a few years ago. He had significant disability with his leg and went through really an extensive orthopedic work, thinking that this could be a back pain issue, multiple injections, this and that. Unfortunately, nobody ruled out PAD, and that's truly what have happened after interventional treatment, endovascular treatment for the right iliac artery. He was able to go back to function. We see these cases all the time in our practice, unfortunately. There's a number of societies that have contributed to current guidelines that was published in 2016. We do expect the newest guideline, a new version of these guidelines, probably with ACC or HA this year. The number of patients that we see with a classic intermittent claudication is probably 11 to 20% of all the patients with peripheral arterial disease. Most of our patients have atypical symptoms, pain, weakness, discomfort, cramping at night. These are the most common symptoms of peripheral arterial disease. I truly believe that the vascular physiologic non-imaging vascular lab is and should be the first stop for these patients. It's truly informative, it's simple and reproducible. If it's done well, you can obtain ABI, segmental, and the pulse wave. And in addition to that, we perform a walk program for them, or a walk set for them, which is a 5-minute at 12.5% elevation. And that gives us a number of values that are important clinically. We can get their maximum walking distance, their pain-free walking time, etc. And these informations in one report is very helpful to address the level of claudication that these patients have. You can nearly know about 80% of the patient history before you go into the room to see the patients, if you have a good physiologic report. Here's an example. Here's a gentleman with near normal resting ABI of the right lower extremity and mild disease on the right. You can see that after he walked for a few minutes on a treadmill, his ABI on the right is about 0.9, which is not bad, but on the left really dropped to 0.3. That's a significant drop. That's over 40 points. Tell you this gentleman is probably have significant claudication. When you put these patients through a walk program, 12-week walk program, that delta shrinks, that delta improves. So they don't drop as much. And that's how you know that your patient is walking, by not seeing that significant drop when you do physiologic testing. When you put a stent or perform angioplasty, the resting ABI increase. And here's just a demonstration of how this patient performed. And you can see that this patient walked 95 yards only before they have to stop. So before you go into the room, you can tell their maximum walking distance. You can tell where the onset of pain is and what's their clinical performance. You can really tell their classical or their grade on the Rutherford classification before you walk in the room, just based on the physiologic studies. So if they walked less than 200 meters, they're either class 3 or 4, and above 200 meters, they're either class 1 or 2. ABI is not only a predictor of limb claudication, but also from the cardiovascular standpoint, it does predict outcome. And we know that the normal ABI should be between 1.1 to 1.4, Anything above that or below that value carries cardiovascular risk. I always like to ask this question to the trainees where I work. I ask them, what is the most prevalent disease? Is it peripheral arterial disease or coronary disease? And they always know the answer. It's truly peripheral arterial disease. So let's talk about some of the non-interventional treatment. Unfortunately, in the world of treating patients with peripheral arterial disease, I find that we're very advanced with catheter and angioplasty. But when it comes to some of the basic principles of foot care, and medical therapy, we sometimes lag behind. So it's very important to talk to the patient, to treat their legs very well, make sure they avoid any trauma, and they partner with podiatry so they can keep their toenails clean and to prevent infection. A supervised walk program, we lobbied very hard to have Medicare approve this program. Unfortunately, the uptake of this has been very slow. I think nearly less than 20% of our PAD patients really compliant with this. It's a wonderful therapy for patients who are class 1 and 2, in my opinion. It's a 12-week program, and patients are expected to walk 200% better at the end of the program compared to when they started. So medical therapeutics have not changed much. We still do aspirin, statin. Lately, anticoagulant have been in this space as well. I still don't see a lot of rivaroxaban 2.5 milligram BID in my PAD patients. I don't think everyone is on them. In my opinion, those that have multivascular disease in the legs, in the neck, and the heart, I think they really would benefit from adding an anticoagulant on top of an antiplatelet. So it's really not screening for other vascular disease, more staging the disease. We really need to look into the neck, the heart, and make sure these patients are at higher prevalence for carotid and coronary disease. We looked at thromboembolism in our database of 45,000 patients with peripheral arterial disease, and there's a real relationship with venous thrombosis in these individuals. And we also looked at the risk of atrial fibrillation, and we found those that have calcified vessels that have an ABI over 1.4 have a higher risk for atrial fibrillation. And we also looked in some of our data at the age of diagnosis. So those diagnosed in their 4th and 5th decade with peripheral arterial disease had a higher risk of cardiovascular events compared to limb events. And we're applying artificial intelligence. We're looking into the pulse wave and how it can predict occlusive disease and even risk. And these data has been recently published. So my take-home point of this, that the ankle brachial index is an important tool that you have to use for diagnosing these patients, but also as a risk predictor for cardiovascular events. Resting ABI and a walk ABI are extremely important and should be the first test that you, when you approach these patients. Imaging with ultrasound and CT should be secondary when you consider intervention for these patients when medical therapy failed. And the last take-home point that, peripheral arterial disease, we all know that carries a higher risk for cardiovascular events, and these patients truly still die from cardiac events. In my opinion, we're not doing enough for these patients to eliminate their risk. We probably can impact it, but not eliminate it. And with that, I conclude. Thank you very much.